Welcome back.
Hello, everyone. We're just going to first show you kind of what we've been through already on our Mind the Bleep series. All of the crossed out things are all of the amazing presentations that some of my colleagues have completed. Today we are doing renal and electrolyte emergencies, and we have some more really interesting topics coming up, as you can see on the screen here. So just a little introduction. My name's Becca. I'm a F2 doctor and I'm working in North Bristol NHS Trust at the moment in Southmead Hospital. I'm currently in orthopaedics, but I did a job as a renal F1 last year. So hopefully I can give you some pearls of wisdom from what I learned in my F1 year. And it should take around 45 minutes and we'll have a little break as well. So to begin, I just wanted to go over what we're going to be talking about today. So the first thing I wanted to speak about was acute kidney injuries, which are extremely common on the wards. Actually, NICE recommends that 1 in 5 admissions to the hospital is complicated by an AKI, and they lead to about 100,000 deaths in secondary care. So as F1s, really important to be able to recognise when someone has an AKI and know what to do about it. I wanted to cover when we should refer to our renal team and our colleagues for help from an F1 perspective. Thinking about some of the complications of renal issues such as hyperkalemia, and then some of our more common electrolyte abnormalities, such as sodium, magnesium, and calcium. So a lot to cover, and we've got about 45 minutes. So thinking about the diagnosis of an AKI, this is probably just recapping stuff that you already know, but as always, good to highlight, and I find myself forgetting this as well. I use the KDIGO criteria. This stands for Kidney Disease Improving Global Outcomes, and this is a global organisation that provides evidence-based clinical practice guidelines for kidney disease. It's very useful if you ever want to check it out. We used it quite a lot when I was on my renal job. So the diagnosis of an AKI includes an increase in 1.5 as a minimum of the baseline over 7 days of creatinine, and an increase, a decrease in 0.3 milligram per deciliter, which to us is 26 micromoles per litre in 48 hours. And we also look at urine output as well, so less than 0.5 milliliter per kilogram per hour for a duration of 6 hours. And that gives us our AKI stage 1. So this table is a lovely representation of the 3 stages of an AKI. So as we just went over, we have that increase in 26 micromoles per litre of creatinine within 48 hours, or we can do a baseline check of 1.5 to 1.9, along with a reduction of urine output. And as this table shows us, this increases for each stage. So a stage 2 AKI will have an increase of 2 to 2.9, our baseline of creatinine, and a urine output of less than 0.5 milligrams per kilogram an hour for 12 hours. And then stage 3 is an increase 3 times our reference creatinine, or commencement on renal replacement therapy, i.e. dialysis. And then the urine output tails off again at less than 0.3 millilitres per kilogram per hour for 24 hours, or anuria for 12 hours. And anuria is defined as less than 100 ml output in 24 hours. If we have a creatinine value in the last 90 days, that's the one that we're going to be using for reference of what stage our AKI is in. So once you recognise that, AKI stage 1, 2 or 3, we want to be thinking about what has caused the AKI. And I'm sure you can all remember from medical school, we used a very common and widely used categorisation of pre-renal causes of an AKI, renal causes of an AKI, and post-renal causes of an AKI. So the definition of these are anything that causes reduced renal perfusion to the kidney, but no actual damage to the kidney, and that would be pre-renal. A renal AKI would be something that's intrinsically damaging to the kidney, and this can be any of the anatomy within the glomeruli, the tubules, our interstitial tissue, or our blood vessels as well. And then a post-renal AKI is an obstruction to the urine outflow distal to the kidneys. We can use this structure to try and think about what has caused the AKI. So I'm just going to give you a couple of seconds to think to yourself a few examples of pre-renal causes, renal causes, and post-renal causes. I just want one or two from each, thinking to the definitions, and I'll just give you a second before I go through them. Okay, so starting with our pre-renal cause. As we said, this is anything that causes a reduction in perfusion to the kidney. So the most common things on the ward that we'll see with this are anything that causes hypovolemia, so hemorrhage, sepsis, low blood pressure. We have congestive heart failure that causes an AKI through hypoperfusion, resulting from a low cardiac output. Renal artery stenosis, which is just reduced kidney perfusion, and pre-renal causes are often drug-induced, and we'll touch on some of the drugs that we want to avoid when a patient has an AKI later. Our renal causes are anything that intrinsically damage the kidney. As an F1, you wouldn't be expected to be investigating for renal causes if you weren't on a renal job. Actually, by the time you got to finding out that your patient did have a renal cause, the kidney team would already be involved, because a lot of these diagnoses require renal biopsies and very specific treatment. But just to give you a few examples, we can have acute tubular necrosis and our nephritic and nephrotic syndromes as well. And then we have our post-renal causes, and this is usually a mechanical obstruction. So we just need to think about all the anatomy that surrounds the kidneys. So do they have a enlarged prostate? Is there a bladder tumour or any injury? Any kidney stones blocking the urine flow? And urethral strictures can be common as well. So we've thought about what stage of AKI the patient's in. We've thought about the potential different causes. We now need to think about how we're going to manage the patient, and actually how we're going to know what AKI they're in clinically. So to do that, I've made a nice little table of all the things that I would look for in a patient if I was going to go and examine them, and I just found out they had an AKI. So unfortunately, AKIs are often asymptomatic and show very non-specific symptoms, such as nausea and just fatigue as well. This can make it quite difficult to determine a cause unless it's an obvious pre-renal hypertensive cause, for example. So let's start with our pre-renal diagnosis. So we've gone through the causes. We know that it's, you're hypovolemic sometimes, you're hypertensive. So we're examining the patient and we're looking for signs of dehydration. I'm sure you're very well apt at doing a fluid balance, but that's what we're going to be focusing on with acute kidney injury. So observation-wise, your patient has low blood pressure. They have a high heart rate usually if they're compensating for the low blood pressure. And we're looking for any signs of clinical dehydration. So cool peripheries, delayed cap refill time. And then moving towards urine output, patients who have a pre-renal AKI usually produce a little bit of urine and are not completely anuric. So we can think about an oliguric picture here. which is usually around 400 to 500 mils of urine over a period of 24 hours. The main thing with a pre-renal AKI is it will respond very positively to fluids. So, thinking about a renal cause, as I said before, as an F1, you wouldn't be expected to manage the renal causes by yourself. It very much depends on what the cause is as to how the patient will present. Usually they're hypertensive. And some examples of some of the systemic features we can think about. So, for example, if your patient had an acute interstitial nephritis, which is almost an allergic reaction from the kidney, you could be thinking about a fever, a rash, the bloods might show eosinophilia. Or if you had a vasculitis cause, you could be thinking about myalgia, rash, again, fever. At this point, renal will be involved. So as an F1, I wouldn't worry yourself too much about the renal causes. Pretty much always the patient is going to have a pre-renal AKI. So when we talk about renal and post-renal, these are kind of the anomalies to the usual presentation. With the renal causes, you're usually oliguric and producing, 400 to 500 mils of urine. And sometimes in the urine, depending on what the cause is, we can have proteinuria and hematuria. But the key thing is that it won't respond very well to fluids, and you need to involve renal early if you think there is a renal cause of the AKI. And then we have our post-renal cause, as we said, which is usually an obstruction to urinary outflow. So you're looking on examination for any signs of acute urinary retention. So does the patient have a palpable distended bladder? Is there any suprapubic tenderness? And then we can have a think about some of the other causes. If they're a man, do they have an enlarged prostate? And often these patients will be overloaded. So you want to look for any signs of either central or peripheral edema. And these patients will be anuric, so production of urine will be less than 100 mils in 24 hours. And again, a key thing to note is that the patient will not respond to fluids. And any nephrologist will come on and tell you this, but when we refer to renal, the most important thing that they always ask is, what is the urine output? So as an F1, one of the best things you can do is insert a catheter, get the nurse to keep a really strict eye on input and output, and I'm sure your renal doctors will love you. So, management of an AKI. This also massively depends on the cause, but we'll start by focusing on a pre-renal cause. So, if your patient is hypovolemic and hemodynamically unstable, you want to give them a fluid bolus immediately. For a pre-renal AKI, you then use maintenance fluids. You don't need to keep bolusing the patient. It will just be 8 to 10 hourly bags of sodium chloride. Again, making sure you've catheterized them so you can see how their urine output picks up with the improvement in their kidney function. We then want to stop any nephrotoxins, adjust any renally cleared drug doses. And I think it's really key to note that pretty much all of our patients are on Clexane, and that needs to be dose reduced with EGFR and creatinine clearance. So if your patient has an AKI, a severe AKI, sometimes it's worth just looking at whether you need to change any of those doses. And then if we're not thinking about pre-renal AKI, the treatment would be more specific. So anything that's a renal AKI cause would have specialist management. For example, often in the rare vasculitises, we use immunosuppression with steroids. And when I say me, I mean the renal team, not you. And then very severe cases may require dialysis, which often can be temporary, just to allow for the kidney to recover and avoid any of the complications. And then our post-renal causes, we need to manage the cause of the obstruction. So sometimes this can involve referring the patient to urology. if they require a nephrostomy or stenting, or treating their BPH. And usually an ultrasound KUB will give us the diagnosis in the first place. And I thought it would be key to kind of go over when you should be involving the renal team as an F1 on the ward. And, you know, it is really important, if you feel out of your depth in managing something, that you escalate to a senior earlier rather than later. The renal team are always very lovely and very happy to help because they love their kidneys and they don't want them damaged. So let's go through when, as an F1, you should be referring to renal. So one of the most important things to think about is if you have an AKI with no clear cause, you don't know what you're treating. So we need renal to be involved to help us figure out what is causing the AKI. If you've tried to manage the AKI and it's not improving, so for example, you've thought that it was a pre-renal AKI, we've given them lots of fluids and there's been no improvement in their kidney function, we then want to speak to the renal team, because actually giving excessive fluids at that point could cause more harm than it could good. If the patient has a stage 3 AKI, so remember our diagnostic criteria for that, which was 3 times our reference creatinine or urine output of less than 0.3 millilitres per kilogram per hour in 12 hours. Or if they have a CKD 4 or 5 and an AKI on top of that. As I mentioned a lot of times now, anything requiring specialist treatment, so any of the renal causes, we'll just hand them straight to renal. Any complications, and it's important to mention that if the patient has a renal transplant, then you should refer to renal straight away as soon as they have an AKI, regardless of the stage of AKI. And then lastly, if you're concerned, because actually if you're concerned, then that means that there's a reason to worry, and you can just get some advice, because even if they don't come and see the patient, they can help us guide the management. I wanted to just put up this slide to highlight the renal drug database, if you don't know about it. It's actually a really good resource for finding information about all medications. It essentially has every drug under the sun on it, and it tells you how you need to dose adjust based on the creatinine clearance and the EGFR. It also includes really useful information about patients who are on dialysis, and tells you how the drugs are being dialyzed, or again, how we need to change the doses. It's really good. I would really recommend it. I used it a lot, and I still use it now day to day to check what doses I should be prescribing and what changes I should be making. While we're on this, let's think about what are the most common nephrotoxins. So I'm just going to give you a few seconds to make a list of 3 common nephrotoxins that we encounter a lot in clinical practice. Okay, I'm hoping that the majority of you have all written down ACE inhibitors, NSAIDs, and diuretics. So these are kind of our triple whammy drugs that a lot of the patients are on, but can cause severe kidney issues. So ACE inhibitors, they dilate our efferent arteriole, reduce the pressure within our glomeruli, and decrease our EGFR. NSAIDs inhibit prostaglandins that normally dilate our afferent arteriole, so dilate the blood vessel, bringing blood to the kidney. So if we're inhibiting this, it's causing constriction and reducing blood flow to the kidney, causing a reduced EGFR. And then our diuretics increase the renal salt and water excretion and cause volume depletion and result in a decrease in intravascular volume, which decreases our renal perfusion pressure and therefore decreases our eGFR. When I say ACE inhibitors, I also mean angiotensin receptor blockers as well. They work exactly the same as ACE inhibitors by causing the efferent arterial dilatation. And then lastly, a lot of antibiotics can really upset our kidneys as well. And these usually cause direct injury by acute tubular necrosis. So if a patient is on any aminoglycosides, it's really important to keep a good eye on their kidney function. So I have a nice acronym for the indications for dialysis. I think this is also really important to cover because actually one of the main reasons that renal will get involved is when there is an indication for dialysis. So it's important for us as clinicians to understand when this may be a requirement if an AKI does end up getting to the point of any of this. So here is my lovely acronym AEIOU, and I'll give you just a second to think about what they could stand for. Okay, so we've got the A for acidosis, and when I say acidosis, I mean a severe metabolic acidosis, so a pH of less than 7.1. We've got E for any of our electrolyte imbalances, but mainly hyperkalemia. And when we say hyperkalemia with dialysis, we mean a refractory hyperkalemia, so high potassium that is not responding to any treatment. This can often be the case where you're doing cycles and cycles of the hyperkalemia treatment and it's just not budging. So dialysis would be needed to remove the potassium from the blood and stop any of the awful cardiac arrhythmias you can get with hyperkalemia. Number 3 is ingestions and intoxication. Number 4 is overload, specifically of your lungs, so any pulmonary edema that's not shifting with diuretics. And then we have U for uremia, and specifically symptomatic uremia, so pericarditis or encephalopathy, which are very rare to see, but can happen with urea levels over 40. And it's important to note that this dialysis can often be temporary, just to allow the kidney function to recover a little bit. And renal do this by inserting a temporary line and using dialysis based off numbers, so checking the renal function every single day to see how it's changing, and then they can decide whether or not they need to keep dialysing the patient. So thinking about one of our main complications of AKI and all things kidney is hyperkalemia. So why hyperkalemia is dangerous is because you have a huge amount of extracellular potassium, which decreases our resting membrane potential and can lead to impaired cardiac conduction and arrhythmias. So basically the heart, we're worried about the heart in hypotassium. I would suggest with any of these electrolyte abnormalities, every single NHS trust should have guidelines on how they like to manage it within the board. So in MBT, we have really good guidelines for hyperkalemia, hyponatremia, all your magnesium and phosphate imbalances. And I still use them in a day-to-day setting because they just give a really clear framework and structure for working things out. So I think if you're ever confused or you don't know what to do, you can always just have a look, and that's what it's there for. It's there for us to follow it. So I just want to reiterate that it's the best thing to do is use guidelines and just live by the guidelines, because I always do that with electrolyte imbalances. So speaking of guidelines, I have decided to upload our North Bristol guideline because I think it is very simple and easy to follow. When we're thinking about hyperkalemia, we want to stop anything that's causing it. So we know that acute kidney injury, as we've spoken about, is one of the main causes of a hyperpotassium. But actually, there are a couple of drugs as well, like potassium-sparing diuretics and ACE inhibitors that would need to be stopped. The first step is looking at whether the potassium is in the mild, moderate, or severe range. With mild potassium, usually you can just monitor it, and you only need to make a change if it rises up to that moderate level. Moderate is when our potassium is greater than 6, and severe is greater than 6.5. For both of these things, the most important thing to do first is get an ECG, because this will guide the initial treatment pathway. If you get an ECG and there are changes on that ECG, we will be starting calcium gluconate IV immediately. We always tend to use calcium gluconate in North Bristol, but you can also use calcium chloride as well. This is for protecting and stabilizing the cardiac membrane. The next thing you need to do is shift the potassium intracellular. So as you can see by my lovely flowchart on the left, we can do this with an insulin glucose IV infusion and some salbutamol nebulizers. Often we prescribe Lokelma as well for about 3 days, and that just goes on all prescription 3 times a day. And that helps to remove the potassium from the body. And if you still weren't getting on top of this, this is when we would be considering dialysis. But yeah, there's always a lovely little flowchart you can follow, and I would just highly recommend sticking to that and just following it step by step. So, ECG changes with hyperkalemia. I'm sure I'm just hammering home what you already know, but I'm just going to give you a second to think about a couple of things that we look for in the ECG, and then we'll go through them, okay? Okay, so as we all know, the first ECG change that you're looking for is peaked T waves. And this is usually the first sign that you get on an ECG when you have a high potassium. The next thing we'd look at is the P wave. You're looking for any flattening or widening, loss of P wave, or any changes to your PR interval. Yeah, as I said, loss of P waves. And then you get your QRS widening, which sometimes your ECG starts to look rather bizarre, and you're getting a lot of changes, including conduction blocks and arrhythmias. This is a very bad sign if you get to QRS widening, because you're really worried about ventricular fibrillation or asystole. But actually, these changes happen incrementally with a rise in potassium. So if your potassium is over 8, this is when you're worried. This is when you would be able to see the asystole and VF, but hopefully you will never get to that point. And I mean, I've never seen a potassium that high before, and you'll have a lot of help on the wards if you've got a refractory potassium, because everyone worries about high potassium. And then I thought we'd just have a nice little illustration of the progressive ECG changes that we can see. So as I said, firstly, we have our tall peaking T waves, then we have a loss of our P wave, then we have our QRS complex and bizarre morphology, and then lastly, when our potassium is at extremely dangerous levels and potentially death, we have asystole and also ventricular fibrillation. But most commonly, you'll be able to see the peaks T waves and occasionally the loss of the P wave, but it should never be getting to the point where you would be seeing the widened QRS or VF or asystole. So here we're going to move on to sodium and sodium imbalances, which are everyone's nemesis on the ward, including mine. And the main one we're going to start with is hyponatremia. So hyponatremia, again, as always, can be categorised into mild, moderate and severe. Commonly, we're seeing on the ward mild to moderate, usually when patients have sodium of less than 120, I would have senior support involved, and less than 115, you're thinking about ITU and some further help. You wouldn't be expected to manage a sodium of less than 115 on your own. Even above 120 can be quite difficult. The thing for sodium to mention is that, it is slow correction is essential. You don't want to increase it too much because you're at risk of osmotic demyelination syndrome. So we aim for no greater than 10 millimole per litre over 24 hours. So if you've had an acute drop of greater than 10 in 24 hours, or you have severe symptoms, so this includes confusion, nausea, lethargy, vomiting, then it requires immediate senior support and will need managing in a controlled and safe environment. Only your seniors are administrating hypotonic saline. That would never be expected of you as an F1. Actually, for hyponatremia, the most important thing you can do is just understand why the patient has a low sodium and start the initial steps and management, and then you can get help. Okay. So when we're thinking about that, the most important thing to think about first is the history of the patient and the context of the hyponatremia. What I mean by this is there an obvious cause as to why the patient has a low sodium? Do they have vomiting and diarrhea? Do they have a low oral intake of fluids? Or are they a surgical patient? Have they just been given IV fluids? And then having a little think about their background, any known liver cirrhosis or any known heart failure. Second thing we want to do, and the most important step in hyponatremia, is assessing the fluid status of the patient. So the same way that we did when we were thinking about AKIs, you're essentially just going to examine the patient, looking at blood pressure, urine output, and clinical signs, either the absence or presence of overload or dehydration. The third thing you need to do as an F1 is to stop all the offending medications. So some examples of this would be PPIs and thiazide diuretics, and some antidepressants can cause a hyponatremia as well. And then lastly, you want to send some paired serum and urine osmolarities and urinary sodium. And as I said, we don't want to correct more than 10 millimole in 24 hours, and we're aiming to correct by less than 6 in the first 6 hours. Okay, so let's have a think about osmolality and interpreting serum and urine osmolarities. So the definition of osmolality is essentially the concentration of dissolved particles in a liquid. And in this case, we're thinking about sodium either in the blood or in the urine. So serum osmolality is a measure of sodium in relation to water in the blood, and urine is a measure of sodium in relation to volume of urine. And then our urinary sodium is just as it is the amount of sodium that we can measure in your urine, and that we look basically the same time you order the serum and urine osmolarities. It's literally just called urine sodium. Very simple. In order to understand our osmolarities, it's important that we go back through this fun little diagram that we all remember of the negative feedback cycle. So our hypothalamus detects an increase in serum osmolality, and by this we mean that there is a increased level of sodium in relation to water, meaning that you're dehydrated. Your ADH then allows, in response to having dehydration and increased serum osmolality, it then allows water reabsorption back into the bloodstream, which in return increases your urine osmolality, i.e. creates more concentrated urine, and decreases your serum osmolality, i.e. causes a more dilute blood, and therefore decreases your serum osmolality. And then this will be detected again by your hypothalamus, and this is our negative feedback loop. So when we're interpreting osmolalities on the ward and urinary sodium, we need to use the patient's fluid status to do this. So we have start with an examination, as I spoke about before, and we'll split it into hypovolemia, euvolemia, and hypervolemia. It's worth noting that your serum osmolality in hyponatremia is usually always decreased, because your serum osmolality is a measure of sodium in relation to water, and our patients are hyponatremic, meaning that their osmolality should be low. If for some reason your patient has an increased serum osmolality, you need to rule out other causes, such as pseudo hyponatremia, which can be caused by high blood glucose. So in hypovolemic states, your patient is dehydrated, they are producing concentrated urine, so therefore, you got sodium and water loss, so you have a decreased circulating volume, but it's worth noting that you have a greater sodium loss than water loss, and that's why you're hyponatremic. The important thing to look at here when you're looking at causes is your urinary sodium, because this can help us distinguish between what is causing this hypovolemic hyponatremia. If you think about it, if you have a low serum sodium, your kidneys should try and hold on to the sodium, and they shouldn't be losing it because they're trying to increase the levels in your blood. So if you have a urinary sodium that is less than 20, that's a good thing, and it means that your kidneys are holding on to sodium appropriately, but the sodium is being lost from somewhere else. So we start to think about GI losses, vomiting and diarrhea. Whereas if your sodium in your if your urinary sodium is greater than 20, then it means that your kidneys aren't conserving sodium, and so this could be a renal cause of a hypovolemic hyponatremia. And the way that we treat this is with rehydration. So in euvolemia, this is a state where you're actually got too much water in relation to sodium, but it's called like a dilutional hyponatremia. So the total amount of sodium in the body remains normal, but the total body water increases, which causes a low concentration of sodium in the blood. It's called euvolemic because essentially the fluid increase is not significant enough to cause any visible edema or volume depletion, and it allows patients to present as normal. In these patients, a low sodium in the blood should prompt the production of dilute urine, because when you're at a euvolemic state, serum sodium is low, so your body attempts to conserve sodium. So if you have a high urine osmolality, then this is abnormal, and this is when we think about our syndrome of inappropriate ADH, because understanding that actually a raised urine osmolality in the presence of a low serum osmolality in euvolemic states suggests that the kidneys are inappropriately excreting sodium, despite having a low serum osmolality. And the management of these patients is to fluid restrict them. And then we have our hypervolemic states, which is hypervolemic hyponatremia. And this is where we have both sodium and water excess, but the water gain is greater than the sodium gain. And again, we can look at the urinary sodium excretion to tell what is the cause of this. So in patients who have a low urinary sodium, they are, the cause of this could be a heart failure or a cirrhosis, whereas patients who have a high volume of urinary sodium, it means that the kidneys aren't working appropriately. So a cause of this could be renal failure. And again, with these patients, we want to fluid restrict them. So I just want to check understanding from that. We're just going to go through 2 questions quickly. So we have a 72-year-old female with diarrhea and vomiting and reduced oral intake. She is now hyponatremic. What would we expect the following to show? Serum osmolality, urine osmolality, and urinary sodium. And I'll give you a few seconds to think about that. So we're thinking that this patient has a hypovolemic hyponatremia. Her serum osmolality will be decreased because this is a true hyponatremia. Her urine osmolality will be increased because she's producing concentrated urine. And her urinary sodium will be decreased because her kidneys are working correctly, and this is extrarenal losses, such as diarrhea and vomiting. And then we'll have this next question, which is a 80-year-old male who's hyponatremic and clinically overloaded. Investigations show an increased urine osmolality and an increased urinary sodium. What is the cause? And again, I'll just give you a couple of seconds to think about that. And here we have renal failure because the patient is hypovolemic and overloaded. They have an increased urine osmolality, which means that they're not producing much urine with an increased sodium content in relative to the urine content. And they have a high urinary sodium, which means that they're losing urinary sodium even though they have a low level of sodium in the blood. So this is inappropriate. And then this is, if you're watching live or not, you can just pause on this. It's a lovely little flow chart that explains it quite well. And I'm quickly just going to whiz through hyponatremia because it's actually really uncommon on the wards. Again, we categorise it into mild, moderate and severe. It's very uncommon and usually caused by dehydration because there's not many circumstances where we're going to be having a high level of sodium in the blood with a high level of water as well. So management is usually with IV fluids to rehydrate the patient and sometimes 5% dextrose. And overcorrection can cause cerebral edema. So we need to be careful with that as well. So just quickly to recap what we've spoken about. We've spoken about the first steps and ensuring that we have a good fluid balance assessment, thinking about any of the obvious causes, organising some paired urine and serum osmolalities, and making sure we use guidelines and flow charts. My advice would be to do something and assess response. So if you think it's pre-renal, there's no harm in giving a little bit of fluid and seeing what the how the sodium reacts, because sometimes that can guide you into knowing that that is the wrong thing to do, and then we can make sure that we fluid restrict. But I would definitely be happy to talk to anyone senior about any worries I have with hyponatremia. So hypomagnesia, again, this is quite common as well. The main causes come from a decreased intake, redistribution, so any refeeding syndromes or acute pancreatitis, any GI losses such as diarrhea and vomiting, and any renal losses as well. This manifests usually with neuromuscular presentations, such as muscle cramps and tremors, some cardiac changes, sometimes hypertension and tachycardia. Metabolic include other electrolyte imbalances, can be associated with hypocalcemia, and some behavioural changes such as irritability and confusion. The treatment is simply replace the magnesium. 0.4 to 0.7, we usually use oral replacement, and if it's less than 0.4, then we would replace IV. And the last one, electrolyte abnormality we're going to go through is calcium. So firstly, let's think about having a low calcium. Things to consider are, firstly, always check the magnesium, because as I just explained, that hypomagnesium and hypocalcemia can often come hand in hand. And hypomagnesium actually impairs your PTH secretion, which is important for regulating your calcium levels and detecting when they are low. So calcium will not correct until magnesium is normal. And this can often be a lag of 2 days from correction of the magnesium. And high phosphate can also lower your calcium as well. So every time you have a patient with hypocalcemia, make sure you find out their magnesium and their phosphate. The two main causes are hypoparathyroidism and a vitamin D deficiency, because your vitamin D helps with calcium absorption. Symptoms of hypocalcemia are much the same as many of the other electrolyte abnormalities. We have neuromuscular excitability, so any muscle spasms or extremity numbness or tingling, some peri-oral tingling as well. That's a very common sign of hypocalcemia. And more towards the severe spectrum, we have seizures and arrhythmias. Again, we treat hypocalcemia with replacement, depending on whether or not the patient is symptomatic. Between levels of 1.9 to 2.2, if they're asymptomatic, we can give them oral replacement, and if they're symptomatic, we can give IV. Anything less than 1.9, we'd usually give the patient IV replacement. And important to keep rechecking the calcium levels as well and monitor that it's effective. And then lastly, we have our hypercalcemia, which we always need to consider malignancy as a cause in, malignancy and dehydration. And we have the classic acronym for the symptoms of hypercalcemia, including bones, stones, moans, and groans. This refers to bone fragility and pain. We have stones as usually kidney stones, so any flank pain. Moans are sort of constipation, nausea, vomiting, and abdo pain. And then our psychic groans, which can be some of the changes that we have neurologically, so fatigue, depression. The treatment of hypercalcemia is rehydration. If it's greater than 2.8 and symptomatic, or greater than 3, then we'd rehydrate with IV fluids, 2 to 3 litres over 24 hours, and then give bisphosphonates. And if it's less than 2.8, then we'll rehydrate and recheck the calcium. And we're aiming for slightly more litres per day, so 3 to 4. So in conclusion, I just want to recap quickly what we've covered. We have looked at the staging and the management of AKIs, the indications for dialysis, the management of hyperkalemia and ECG changes, sodium abnormalities and osmolalities, including serum and urine osmolalities and urinary sodium, and the management of magnesium and calcium imbalances. So here's kind of advertising some of the exclusive discount codes that Mind the Bleep offer. if you're watching live, then you can go back and look at this on the mainstream.
Amazing.
Thank you so much.
And I think on the next slide there should be
the feedback form.
Thank you.
So yeah, thank you so much,
Becca.
Thank you for your time. And if you could please speed up, give in the feedback form, that'd be amazing.
Thank you so much.